In this session at Medical Sciences, today we are privileged to take you through what we call white blood cell abnormalities. You can call it leukocyte abnormalities. There are two different types of white blood abnormalities, that is qualitative and quantitative. Under quantitative, we have those due to malignance, that is cancers that can be malignant or non-malignant. Then we have also those with that is under malignant, we have what we can call cancerous cells like leukemias. Whereas under non-malignant, we have those with increased count and those with decreased count. But under qualitative, which is our major emphasis today, under white blood cell abnormalities, in another video we shall look at quantitative, but in this video we want to zero on the qualitative white blood cell abnormalities. So today we are looking at the qualitative white blood cell abnormalities. And these qualitative white blood cell abnormalities can either be due to morphological change or due to morphologic abnormalities, as we are going to see. And as we start, we remind you to subscribe if it is your first time, like the video, and share to many others. So, qualitative abnormality number one. And we are saying, what is qualitative? Qualitative is change in functioning of the cell. So we want to see which abnormalities affect normal functioning of white blood cells. So we want to begin with hypersegmentation. So number one, we are looking at hypersegmentation. This one you can call it right shift. Right shift according to Cook nth count. Because Cook nth count took time to count lobes of neutrophils, and he found out that normal neutrophils have lobes between 3 to 5. And any neutrophil having lobes greater than 5, that one is regarded as a hypersegmented neutrophil, whereas those ones with 2 and below are hyposegmented. So with right shift, which we are calling hypersegmentation, is whereby you find a neutrophil with greater than 5 lobes, whereby the nucleus is segmented into more 5 lobes, and this one is always seen majorly in the neutrophils. So when we see the majority of the neutrophils having lobes greater than 5, we can suspect this hypersegmentation, and it is majorly seen in megaloblastic anemia. It's seen in megaloblastic anemia and pernicious anemia. So these two types of anemias, we can find hypersegmented neutrophils due to lack of vitamin B12 and folic acid. And how does it look like? If we have a neutrophil, this is a neutrophil, you find a neutrophil with many lobes. Lobes always greater than 5. So if you find a neutrophil in someone's peripheral blood film with lobes 1, 2, 3, 4, 5, 6, 7, any neutrophil with lobes greater than 5, we are calling it hypersegmented, and we have seen it in megaloblastic anemia and pernicious anemia. Pernicious anemia is due to lack of intrinsic factor, and without intrinsic factor you cannot absorb vitamin B12, hence resulting into a form of megaloblastic anemia. So that is number one we can discuss with you. Then the second one we are going to discuss with you in this session is overload. You can call it overload, or you can pronounce it as Auer load. This Auer load is seen in megaloblasts, or what we can call myeloblast cells. So it is majorly found in myeloblasts. This one you can majorly find it in myeloblast cells, whereby these are rod-like structures which are pink. They are pink or red in color. They tend to be like acid-fast bacilli when you stain with Zn looking for Mycobacteria tuberculosis. They are always pink and found in the cytoplasm, in that if I have a myeloblast, if this is a myeloblast, within this myeloblast, which is found in the bone marrow, or it can be found in the periphery in the presence of leukemias, you find the nucleus is always eccentric. And if this is the nucleus with some nucleoli, you find our rod is just a red or pink rod within a cytoplasm. So this is what we are naming our rod or our rod. And it is majorly found in conditions such as chronic myeloid leukemia and acute myeloid leukemia. So leukemias which originate from myeloid cells, we can find our rods. And it is this rod that enables us to distinguish between myeloid leukemia from lymphoblastic leukemia. That is presence of our rods within the cytoplasm of immature cells, specifically myeloblasts. Hope you're getting me. Then the third one we can discuss in this session, hope you're going to enjoy this video, is what we call Pelger-Huet cell. Some books call it, we have what we call pseudopelga and pelga. How does pelgarized cell look like? Pelger-Huet anomaly. So this anomaly, which we are calling Pelger-Huet anomaly, the red, you find segmented cells like neutrophils having lobes less than 2. So here we find neutrophils and band cells fail to segment to form more than 2 lobes. So they end up being hyposegmented. And for example, if I have a neutrophil at this stage, this is a neutrophil, you find it has only, you find a neutrophil with only 2 lobes. So this is what we are calling pelgarized cell. These cells, they are hyposegmented in that the nuclear lobes fail to segment to form more lobes. They end up having only 2 lobes. This is what we are calling Pelger-Huet anomaly. This is genetic, so meaning it is inherited, and it is autosomal recessive disorder. And this one can be seen in conditions like leukemias. In conditions like leukemias, that is cancer affecting the white blood cell, we can see Pelger-Huet anomaly. And another condition we can find it is infectious mononucleosis. Infectious mononucleosis. These are the 2 conditions where you can find pelgarized cells or Pelger-Huet anomaly. The 4th abnormality, because today we are going to discuss like more than 10 factors, 10 abnormalities. So from Pelger-Huet, we are going to look at a cell known as a TAT and a Lee cell. So we are going to look at a TAT cell, and this TAT cell, we are going to take it vis-a-vis a Lee cell. So this is going to be our number 5. Why I'm taking these 2 at the same time, they almost resemble each other. But the TAT cell is strictly found in the monocyte, whereas Lee cell is found in neutrophils. Neutrophils and some band cells can be found. So this is erythromatosis. It is found in a condition known as, you can find it in systemic lupus erythromatosus. So this is lupus erythromatosus cell. So if someone has a condition of SLE, which is an autoimmune disorder, you can easily find these neutrophils or bands in the bone marrow which have ingested nuclear material. But what distinguishes these two? We are saying this is a monocyte. You find a monocyte, it has ingested a nuclear material. So this is a nuclear material which it has ingested. Then the nucleus end up being, so the nucleus is pushed to one end. So this is the nucleus of the monocyte. Then this is the ingested mass, but with the third cell, it is intact, so you can easily see the chromatin pattern. The chromatin pattern within the ingested nuclear mass is seen, which is different from Lee cell. With the Lee cell, if this is a neutrophil, the neutrophil has ingested a nuclear mass, but it is homogeneous. The stain is homogeneous. It is a homogeneous mass, which you cannot see the chromatin pattern, but still the nucleus is still pushed to one end. So this is the nucleus, then this is the ingested mass, which is homogeneous staining with no chromatin dot. So this one at the side, this is what we are calling the nucleus of the neutrophil, which has been pushed at a side. This is the ingested nuclear mass, which has been disintegrated, but this one is intact. So the nuclear one, which has been phagocytosized, is intact, whereas here it is disintegrated and the stain is homogeneous. And we have said this is found in neutrophils, whereas this is found in monocytes, but all cells have phagocytosized or engulfed nuclear material. But here the nuclear material is disintegrated, here the nuclear material is intact. So this one is found in normal monocytes and monocytes, which have just ingested the nuclear material of a foreign body. Whereas the Lee cell is found in autoimmune disorder like systemic lupus erythromatosus, which ingests a disintegrated nuclear mass and pushes the nucleus at the periphery. That is what we can talk about a Lee cell. But almost morphologically, they are the same, they only define the location. That is the difference between a third cell and lupus erythromatosus cell. So number 6, we are going to discuss about other abnormalities, which we are going to look at Döhle body. We have what we call number 7. Number 6, we are going to talk about Döhle body. And the Döhle body is going to be versus May-Hegglin. May-Hegglin anomaly. So these are also 2 different abnormalities found in white blood cells, which all look like the same, but they differ on how they are acquired. Whereas we are going to see Döhle bodies, this one is acquired, whereas this one is inherited, that is genetic. This one is genetical, whereas the Döhle body is inherited. So this one is acquired due to infection, whereas May-Hegglin anomaly is a genetic disorder which is inherited from parents. And how do they differ? We're going to tell you that Döhle bodies, if I have a white blood cell, especially the neutrophil, This is a neutrophil with its lobes. This one is my normal neutrophil with its cytoplasmic granules. So you find a door body is due to polymerization of the ribosome. So it is a pale staining round body, is pale staining found at the periphery of a neutrophil. So this is what we are calling a door body. This is a door body, and it is always pale blue staining, and it is due to polymerization of ribosomes and rough endoplasmic reticulum. Whereas with May-Hegglin anomaly, this one can occur in all types of white blood cells. That if I have, you can have a monocyte, a neutrophil, a lymphocyte. But in this case, I want to use a neutrophil. So if I have a neutrophil, which is with normal nuclear lobes, you find this one is pale blue staining, whereas this is dark blue staining and prominent. So this one is more prominent than the door body. So this is dark blue staining, prominent door-like body. This is a door-like body. Door-like. But it is larger than the door body. And this one stains pale blue, whereas this one stains dark blue and very prominent, all of them located in the periphery of white blood cells. As we have said, door bodies are found majorly in the neutrophils. So we are seeing door bodies majorly found in neutrophils. Whereas May-Hegglin anomaly can be found in majorly all white blood cells. And we said it is genetic disorder. So this one is seen in conditions. This one is seen in conditions such as leukemia. You can find it in leukemias, whereas door body we find the conditions like severe infections. We can see it. You can find it in burns and chemical poison. But all of them, as they are due to polymerization of ribosomes and rough endoplasmic reticulum. So this is how you can distinguish between a May-Hegglin anomaly and a door body. But apart from that, how do you know that it is May-Hegglin anomaly, not a door body? May-Hegglin anomaly is associated with giant platelets. You find this one is associated with giant platelets, and there is always low platelet count. That's what we call thrombocytopenia. Whereas this one, the platelet size is normal and there is no thrombocytopenia. So these are the distinguishing features you can use. So there is a triad of the inclusion body, that is door-like body. You find a giant platelets. You also find low platelet count. Whereas here, the platelets are normal in size and in count. That is the difference between door body and May-Hegglin anomaly. So number 8, we are going to discuss with you about toxic granulations. Toxic granulations. And these toxic granulations, we are going to discuss them together with number 9, which we are going to call Alder anomaly. We have Alder anomaly. Then at the same time, we are going to compare it with number 10, which we are going to call it Chediak-Higashi anomaly. Chediak-Higashi Chediak-Higashi anomaly. Or cell. So these ones we want to discuss with them, whereby with the toxic granulations, they are majorly found in neutrophils and immature cells which are neutrophilic, like the band and the myeloblast. And if this is a neutrophil, we are going to find that this neutrophil, it has its normal lobes. Those are 3 lobes of the neutrophil. But the difference from the normal neutrophil, this one has large, prominent dark blue staining granules. So you find there is dark blue staining granules which are prominent, numerous and prominent than the normal. So you find the neutrophil is having these dark blue, numerous staining granules, which are very many than the normal granules in the nucleus. So if you find this implies someone might be having severe bacterial infection. Someone with a severe bacterial infection and any other infection, you can see toxic granulations, people with burns and drug poisoning. These are the conditions where you find toxic granulations in neutrophils. Whereas Alder anomaly, if this is a neutrophil, if this is a cell, this one can be found in neutrophils, in lymphocytes, in monocytes. So this one can be found in all these 3, whereas this one is majorly located in neutrophils and band, the immature neutrophils, which are not yet segmented. That if I have a neutrophil, which is this with its nucleus, which has 3 lobes, these granules are slightly larger than toxic granulations. So you find this one has prominent, or you can call them large granules in the cytoplasm. So these are dark blue large granules within the cytoplasm of the neutrophil. It can be in the lymphocytes, it can be in the monocytes. As these toxic granulations are acquired due to infections, this one is genetic. So Alder anomaly is genetic, so it is inherited disorder. It is an inherited disorder, and these granules are due to lysosomal disorder, lysosome storage disorder, whereby some individuals are born without enzymes to digest mucopolysaccharide. So these ones, they lack enzyme to digest mucopolysaccharide. And since they cannot digest mucopolysaccharide, it remains within the lysosomes, leading to these large dark blue staining granules. So this is due to lysosomal storage disease, whereby an individual is born without enzymes to digest mucopolysaccharide, seen in a condition like mucopolysaccharidosis and also Hunter's syndrome. So in conditions like mucopolysaccharidosis and Hunter's syndrome, we find there Alder anomalies, which are dark blue or dark purple large staining granules within the cytoplasm. In size, they are larger than the toxic granulations. These ones, when you're drawing them, they must be somehow larger and prominent than the toxic granulations. Then we can talk about the Chediak-Higashi anomaly. This Chediak-Higashi anomaly can also affect the neutrophils, the lymphocytes, and the monocytes. That, in other words, if we have a cell which can be either a neutrophil or a lymphocyte, but I like using a neutrophil, these ones are very large. Here we are saying it has a very large dark staining granules, dark coarse granules, purple staining granules in the cytoplasm. So how do they differ from these ones? These ones, they are very dark, and these dark staining granules can either be red in color or purple in color. But they are very prominent and very large in the cytoplasm. You find them, they are very giant in the cytoplasm of white blood cells. So the difference is in the size and dark staining, but majorly the size, which can either be purple or red staining prominent granules in the cytoplasm of white blood cells. So this is what we are calling Chediak-Higashi anomaly. It is a seen in a condition known as Chediak-Higashi syndrome, which is an inherited disorder. This disorder is very fatal. Majorly, people who inherit this Chediak-Higashi anomaly, the major syndrome, they normally die before 10 years. So this is fatal, whereas Alder anomaly is not fatal. And we have seen, according to the size of the granules, these are very large, whereas these are large. These ones are due to lysosome storage disease disorder, whereas this is due to lysosome transport disorder. That is Chediak-Higashi anomaly found in the white blood cells. Then another abnormality we are going to discuss as we are winding up with our session is drumstick. We are going to have an anomaly known as drumstick, which is going to be number 11. So number 11, we are talking about a drumstick. And this drumstick is majorly found in the neutrophils. If you have a neutrophil with 3 lobes, so you find a neutrophil with an appendage or a drumstick. And this appendage, which we are calling a drumstick, is majorly found in female due to extra X chromosome. But if you find it in blood, in a PBF from a male, we are going to, if this is a drumstick found in a PBF of a male, this drumstick indicates what we call Klinefelter's syndrome. Klinefelter's syndrome, whereby a man is born with extra XXY chromosome. So these are male who look like female due to the extra X chromosome, and they have characteristics of female. And majorly they become impotent with stunted growth. So this is what we are calling Klinefelter. So if you are examining a PBF, you find a drumstick with the majority of the neutrophils having a drumstick in them, you can end up querying Klinefelter syndrome. But in a female, it is normal due to their extra X chromosome. That is what we can talk about a drumstick. Its other name, you can call it a bar body. It can also be called a bar body, found in Klinefelter's syndrome. So these are the things we can discuss with you in this session about the abnormalities in white blood cells, where we have seen hypersegmentation, we have talked about Pelger-Huet anomaly, overload, heart cell, Lee cell, Döhle body, May-Hegglin anomaly. We have looked at the toxic granulations, Alder anomaly. We have looked at Chediak-Higashi, and we have ended up with the drumstick, which we have called a bar body. Hope you have enjoyed with us. In case you asked an exam to outline NF5 or to explain, you should be able to draw and explain, whereby you describe, you draw, and you give us the condition where that abnormality can be found. Thank you so much. May God bless you.